Dear colleagues, it is my honor to speak to you today about intraoperative radiotherapy for early breast cancer in the course of breast-conserving surgery, about the rationale for the routine use, and some data for special indications. My name is Hans-Christian Kolberg. I am head of department for obstetrics and gynecology in the Marienhospital in Bottrop, an academic teaching hospital of the University of Duisburg-Essen. We are a certified breast cancer center, a certified gynecologic cancer center, and a certified fetal-maternal medicine center. And we have started intraoperative radiotherapy 13 years ago now, and we have performed more than 1,000 procedures in my department. I thank the organizers for inviting me to talk about one of my favorite subjects. Here are my financial disclosures. You may see that I also received fees from Carsize Meditech, the manufacturer of the Intrabeam device. Let's talk first about the use in clinical routine, because that is actually, when you start doing intraoperative radiotherapy, what is moving you most. You can see here, these are slides from the AGO, the German guideline group, they demonstrate that radiotherapy has arrived in the standard of care in early breast cancer as a boost. And here you see that for a boost radiotherapy, you see in the, I just have to look, the lowest line, I mean the second from the bottom. So you see intraoperative boost radiation with a plus, a recommendation for using intraoperative radiotherapy as a boost. And let's take a look at the data that led to that recommendation. Here you see on the left-hand side data from 2008 from Jay Vaidya, one of the nesters of intraoperative radiotherapy and a good friend of mine. We've done a lot of scientific work together. You can see here in an unselected patients cohort of more than 300 patients, you see the local recurrence rate with intraoperative boost with 1.73%, which is extremely attractive and a lot better than was in the EORTC data for the boost that were published before. And on the right-hand side, you see kind of the German experience. A little smaller group, a group that was a little smaller, about 150 patients from Frederick Wenz. Maybe you've heard that name before too, because he also was one of the TARGIT-A investigators together with Jai Vaidya, and he found almost the same, a local control after 98 in 5 years, 98.5%, which actually translates into the same result as Jay Vaidya's data with a local recurrence rate of 1.73% and an overall survival rate of 87%. Or you have to always have to keep in mind an unselected cohort, but of course a cohort that is enriched by high-risk patients because of the fact that low-risk patients usually do not receive the boost irradiation. And these results can be reproduced for IORT or IOERT intraoperative boost data. You can see data for the IOERT here, always mentioned in the method as electrons, and the IORT, this is mentioned here as the 50 kilovolt X-ray source, and you see that the local recurrence rates are almost in all studies about the same. One study is a little difficult to explain. That's from Bartelink in 2001, but that actually was the beginning of when we did that. And one study with brachytherapy. All other studies are in the range between 0.5 or 2.5% of local recurrences in the first 5 years. And that actually is a good result, because you always have to keep in mind patients with a with a boost irradiation are patients with a high risk of local recurrence. That's why they are receiving the boost. But it's also become a standard of care, or a standard of care as definitive radiotherapy. Of course, in selected cases, as part of the concept of partial breast irradiation, and intraoperative radiotherapy is recommended in Germany for patients only over 70 years. I'm not so really sure how the German guideline group. I'm also in one of the German guideline groups. This is another guideline group, and I have to say it's the one where my wife is member. And I asked her, and she couldn't remember why they chose 70 years. We're not really sure, because the data would allow to do that over 50 years, and that's actually how we recommend it to. You will see that the ASTRO guidelines also say 50 years. But what I wanted to demonstrate here, also as a definitive and only radiotherapy, it is part of guideline concepts. And the reason for that is mainly the TARGIT-A trial. In the TARGIT-A trial, the investigators led by Jay Vaidya followed a risk-adapted approach, meaning that patients suitable for breast-conserving surgery were randomized 1-to-1 for the target group or the external beam radiation group, EBRT group, and the patients in the control group, in the EBRT group, received between 40 and 56 gray in 15 to 25 fractions, plus minus a boost therapy, as a whole breast irradiation. And in the target group, patients received a single dose of intraoperative radiotherapy with the intrabeam device. The very important factor of risk adaptation discriminates this study from other trials like the IORT trial, where only 1-to-1 randomization was done with results that were not as good as in the TARGIT-A trial. Just keep in mind, maybe it's not the technique, maybe it is actually the risk adaptation. Because if patients had unsuspected lobular carcinoma, lymphovascular invasions, or other risk factors, patients were defined as high risk and also received whole breast irradiation. And in that case, the target IORT was considered a boost. And this was the case in about 15% of the patients. So very important, if you want to have the same results as in the TARGIT-A trial, you must look at the pathology report after surgery and decide if you will just keep it at that and keep it at intraoperative radiotherapy, or if this patient belongs to those 15% of patients that are that had received a whole breast irradiation also in the TARGIT-A trial. The risk criteria were, as I said, lobular carcinoma, lymphovascular invasion, but also in some cases not complete resection, so R1 situations. Here you see the consort diagram, and actually that is important. I just showed it. I don't want to go through the single parts here. There's two things I want to demonstrate in here. One thing is, this is not a small analysis. It is analysis that is based on the data of almost 2,300 patients. And here you can see age over 45 and not over 70. So age over 45, patients were enrolled and were then allocated to target IORT or to whole breast irradiation. Then you can see here 241 patients in that trial received target IORT plus EBRT. This is important. This number is also not small. It's 240 patients, and we derive a lot of confidence in using IORT as an anticipated boost from that trial here, because also safety data are important. So actually, we know we can do that. Here you can see the long-term results that Jay Vaidya published in the British Medical Journal about 2 years ago. And you can see here the follow-up was 12 years. And you can see here that there is no difference in local recurrence-free survival, no difference in invasive local recurrence-free survival, no difference in breast cancer-specific survival, also mastectomy-free survival, distant disease-free survival was not different. Non-breast cancer survival was actually better for the target IORT group than for the whole breast irradiation group, and overall survival was not different. So actually, those 85% of patients who received only an IORT, and those 15% that also received a whole breast irradiation in that trial did not do worse than the patients who received a whole breast irradiation. And that's actually what the trial wanted to demonstrate, that it's possible to de-escalate and to use whole breast irradiation as only as an exit strategy and not as the primary strategy of radiation. Here you can see the data worked up in another way. Max Bozara, the statistician of the TARGIT-A trial, I also had the honor to work with him for some of my scientific projects, is always keen on really demonstrating what you can see in a curve, so you don't have to look at figures. And that is actually I like those pictures very much, because you can see overall mortality is from the tendency a little higher in the EBRT group. It is not statistically significant, so we cannot say that mortality is worse in the EBRT group, but it's definitely correct. And you can see that on the left hand, in the lower graph, that the non-breast cancer mortality is significantly lower in the target group than in the whole breast irradiation group. We're not really sure yet how this is, why this is happening. Maybe it has something to do with cardiovascular diseases, new cardiovascular diseases, or complications of cardiovascular diseases. We will come to that in the further course of the presentation too. Breast cancer mortality was not different between those two groups, so it is oncologically definitely safe to use whole breast irradiation in the patients that we are selecting, in most cases according to ASTRO guidelines, or at least to the much more strict guidelines of the German recommendation group from the AGO. You see here from the British Journal of Cancer, also publication of Jay Vaidya, new biological and clinical insights from the TARGIT-A trial. And you can see here that the targeted intraoperative therapy, radiotherapy is safe and effective in actually all subgroups, not depending on tumor size, not depending on ER, PR, HER2 status, not on lymph node involvement. So actually there's overall survival on the right hand side, there's local recurrence-free survival on the left hand side. No group is statistically different, so actually target IORT is definitely in the overall survival criteria. It is from a tendency a little better than EBRT, but not significant. On the left-hand side, you can see that in local control, EBRT is from the tendency a smidge better, but not really significant. So there's no real differences, and you don't have the problem of irradiation for between 15 and 25 days for a patient. So actually, in my opinion, this is actually rational enough to use that option. And here you see a cross-trial comparison of IORT, IOERT, and accelerated partial breast irradiation, usually with multi-catheter brachytherapy, or in the study with Levy with intensity modulated radiotherapy. And you can see here that the number of patients in the Elliott trial was 1,300 patients. You can see here the difference between local recurrence between the IORT group and the whole breast irradiation group, 0.4 versus 4.4%. This is definitely not meeting the non-inferiority criteria that the authors stated before starting the trial. Of course, it's still the factor 10, and actually that is what many radiation oncologists are citing or referencing to when they say that maybe whole breast irradiation is safer. You have to keep in mind the Elliott trial, and this is actually why I demonstrated that here. The Elliott trial did not do a risk-adapted randomization approach, but they randomized 1-to-1 and then treated the patient no matter what was in the path report. And this, I believe, is why they have this huge difference, whereas it's not a statistically significant difference between whole breast irradiation and intraoperative radiotherapy in the TARGIT-A trial, and also as kind of a proof of concept, also not in the cases of multi-catheter brachytherapy. Here you see the ABPI statement of the ASTRO, published in the Green Journal, Practical Radiation Oncology in 2017. And you can see here the age group that is suitable is over 50, margins preferably over 2 millimeters, although I'm not really completely sure where they have that from. Then the size, better smaller than 2 centimeters, unsuitable, really unsuitable over 3 centimeters. So it's also always a question of the tumor size. Also because we have applicators going up to 5 centimeters, and we need to be able to put them into the wound cavity, and you usually don't resect a 3 centimeter lump with a segment that is 3 times 3 centimeters. So actually, it's also a question of the applicators we can use. No lymphovascular invasion. That is important, and that's something we are looking very strongly here in my department. If patients have a lymphovascular invasion in the final pathology report, they receive an additional whole breast irradiation. Unifocal tumors and no nodal involvement. If you have a nodal involvement, you do the whole breast irradiation. That is actually why these numbers were leveled in the TARGIT-A trial, because there was this possibility of correcting for that by using whole breast irradiation. And that is exactly what we do here. If patients are candidates for whole breast irradiation as a definitive radiation, we do the IORT and then look at the path report and add whole breast irradiation in cases of high risk, according to the ASTRO statement, but always a little in line also with the German DGRO statements that are a little more strict, as I just demonstrated. But this is actually what is in the guidelines, and that's what we're doing already. There are some special indications. So we have done here, and we have done some studies and analysis about that. And I want to demonstrate that because I want to demonstrate how much you can do with IORT and how many patients where you believe, oh, I would never be able to do that in those patients. You still can do it, and it's safe. I will demonstrate our own data and the experience after over 1,000 cases. So target IORT is also an option in breast tumor recurrence after breast conserving surgery. And you can see here that this is in the guideline. You see here re-BCIS with tumor-free margins, and partial breast irradiation has a plus as a recommendation. And that is actually what we also offer patients. And in the analysis that we had just published 6 weeks ago, patients were included if they had undergone mastectomy or second breast conserving surgery with target IORT for intumor breast recurrence, with no distant disease and existing follow-up data. We could include 36 patients. This is a small analysis, but breast recurrence is a rare condition. 21 patients received mastectomy, 15 patients received breast conserving surgery, and IORT with the intrabeam device. Identified patients were contacted and offered participation, and they filled in the BreastQ questionnaire, and we looked at some parameters that I will demonstrate in a few minutes. You can see here the patient characteristics, and that is extremely important. They were well balanced. As you see, just focus on the right column, you see the p-values, everything is leveled, no significant differences. That is very important because you would think there could be a selection bias, because maybe patients with a better risk choosing breast conserving surgery and patients with a higher risk choosing mastectomy. That's not the case. Both groups are absolutely balanced. And here in the results, you can see we have a long mean follow-up, 12.8 years since primary diagnosis and 4.2 years since recurrence. We could see no differences between both groups regarding age, ER, PR, HER2 status, tumor size, nodal status, tumor histology grade, use of neoadjuvant chemotherapy. We had a numerically longer OS for breast conserving surgery and IORT, either calculated from primary diagnosis or from recurrence. But we did no formal analysis in this. We did one other formal analysis with a mean, and that was not statistically significant. There was only one death of a patient in the breast conserving group, and 3 patients in the mastectomy group died during the follow-up. And here you see the mean DFS differing not significantly, almost 0.8 0.86, but not significantly between both groups, and overall survival and since primary diagnosis and since local recurrence were numerically a little longer, but not really clinically meaningful longer. But the DFS of 7.7 years versus 11.7 years in the mean, that sounds to me interesting, although it's not significant. So what we can definitely say is it's not a risk for patients to leave their breast intact and do IORT instead of removing the breast. We also looked at their quality of life, and we had a significantly superior physical well-being for those whose breast could be preserved, the p-value of 0.021, and very important and reported for the first time to my knowledge, incidence and severity of lymphedema of the arm and the site of surgery was significantly worse in the mastectomy group, with a highly significant p-value of 0.007. You can see this here in the table, as you just saw before. All the other aspects were not significantly different. So, in breast conserving surgery and radiotherapy is an option for patients with an in-breast tumor recurrence, with the right selection of patients. Second unusual indication is after neoadjuvant therapy as a boost, as an anticipated boost, not as the definitive radiotherapy, but as an anticipated boost. And the rationale for that is that IORT has become one of the standards in many centers as a part of breast conserving therapy to obtain better local control. Although that is the case, patients after neoadjuvant chemotherapy are often excluded from the standard. The number of patients receiving neoadjuvant chemotherapy is rising rapidly in our center. The ratio between neoadjuvant versus adjuvant chemotherapy is 9:1. So if we know a patient needs a chemotherapy, we always do that chemotherapy as a neoadjuvant therapy. We only do adjuvant chemotherapies in cases where we are surprised by facts that we did not know from the Korka biopsy, because we know the grading, we know the receptor status, we know the HER2 status, we know the size from the ultrasound, we know the node status because we have ultrasound and we do Korka biopsies of the nodes. So we know everything we need to know about chemotherapy indications, and that is why we do that chemotherapy usually before surgery. Very likely, the high-risk group of patients after neoadjuvant chemotherapy will have the biggest relative benefit from the boost being delivered as IORT because of the better local control. That is what we expected. And then we looked at 116 patients with an indication for breast-conserving therapy, all indication for a boost irradiation, an expected wound cavity of 4.5 centimeters or smaller because of the size of the applicators, and all patients had received a neoadjuvant chemotherapy with or without Herceptin in cases of HER2-positive breast cancer. Patients were received either an intraoperative boost during breast-conserving therapy with 20 gray with the intrabeam versus the external boost with 10 to 16 gray, and all patients received a whole breast irradiation with 50 gray, though that was done in the times before hyperfractionation. The median follow-up was over 4 years, and here you see the same curves as in the TARGIT-A trial, because that statistical analysis was also done by Max Bulsara, and we're very, very proud of working with him on that. And you can see here the local recurrence-free survival is 10% better in the IORT group than in the external boost group, but the p-value was not statistically significant. What definitely was different was the distant disease-free survival. That was numerically 26% better in the target group, and that was statistically significant. The disease-free survival was also 17% better in the whole numbers, but that was not significant. So in none of the parameters, IORT as an anticipated boost was inferior, but superiority could only be demonstrated for distant disease-free survival, and that is important for overall survival. Patients live significantly longer in the IORT group, and that was not because of breast cancer. You can see that here on the right-hand side. And if you now move down to the left-hand side to the lower graph, you can see that was completely triggered by non-breast cancer deaths. And we looked at the causes of death of all patients, and you can see here that there was that the rate of patients dying of breast cancer was half. You could see that in the graph just above, but that was statistically not significant. But all other causes of death in the in the external boost group were myocardial infarction, pulmonary embolism, or stroke, all vessel-associated toxicity. And we can only speculate at the moment why this is happening. One explanation that we can think of is that the induction of the microRNA 223 in breast tissue after IORT leads to the downregulation of EGF and reduced activation of epidermal growth factor receptor. That has been demonstrated in vitro by Fabris in Oncogene 2016, and it is in line with data from the TARGIT-A trial that demonstrated a reduced non-breast cancer mortality and a reduced rate of coronary artery disease and myocardial infarction in patients after IORT in the TARGIT-A trial. So that is very interesting. The TARGIT-B trial, also performed by Jay Vaidya, that is looking at the anticipated boost prospectively, will also look at that, and we are very keen on learning what Jay will find out there. The third and last unusual indication I want to talk about is the patients with implants. Targeted intraoperative radiotherapy is, as we already have learned, a standard option for during breast conserving surgery. And we have more than 20,000 patients in 300 centers all over the world being treated. I think the number is even bigger now. That was when we wrote that publication. No data have yet until we did that been published regarding of the safety of target with implants in situ, although the number of patients presenting with with a status after implant breast augmentation is growing, and we see those patients almost every day now in our department, although not all of those have breast cancer. There was only one cohort being published in 2014, and it was done with ABPI, and actually there was only a follow-up between 1.2 and 58 months, and these patients, it was only reported that I think that no patient died, and more or less it was about safety, because of the high rate of capsular fibrosis, if you do EBRT in patients that had breast cancer and have implants, target RPT can be an important issue for those patients, and this is why we did a worldwide call. It was very difficult, as you can see, to really identify patients. We identified 16 patients from New Zealand, from California, from two sites from California, Valerie Uhl and Dennis Holmes, one or two patients from Italy, from Samuele Massarut, from Aviano, some cases from my department, and some cases from New Zealand. So actually it was Erica Weiner-Kelly was the investigator in New Zealand. These patients had all had breast conserving surgery for early breast cancer, had undergone breast augmentation before, and wanted their implants to stay in situ. All patients had been informed that no published data existed, but they still decided to keep their implants. All patients received target IORT. 3 of those patients received additional whole breast irradiation after target IORT because of the presence of external predominant intraductal disease or lymphovascular invasion. Extensive is the word. That's the E here. And all patients received endocrine therapy according to local standard. And here you can see what these patients had. There was one patient, I think, with a single DCIS in there. One patient even had a lymph node involved, but only microinvasion. You can see the follow-up was very different between the patients between 5 and 98 months. Grade was between 2 or 3 with grade 1, some even with grade 3. The group was very heterogeneous, but still the result was very promising. The follow-up varied from there was an updated table from 98 to 6 months. 11 patients presented with invasive breast cancer and 1 patient with DCIS. There were no procedure-related complications, and none of the patients had needed the implant removed. 1 patient was diagnosed with a local recurrence in a distant quadrant after 36 months of follow-up, and no breast cancer-related events occurred in the other patients. So, also in patients with implants, there is an option for using intraoperative radiotherapy for sparing these patients external beam radiation, which would lead to a capsular contracture rate of between 50 and 60%. And now, why are we talking about IORT? Very briefly at the end, why are we talking about IORT here at that meeting? And actually, there is not a lot of information about IORT on the African continent, but there was one publication that I read when it came out 2 years ago, and I didn't forget it. It was the first IORT therapy center in Africa. I think it's in South Africa. I'm not so sure how much it is comparable with the rest of Africa, but still it was the first center. I think they started operations in 2017, and they demonstrated their first results. I don't want to talk about the results in the JCO, in the special part of the JCO for global oncology, and there was 2 things that I wanted to demonstrate here, and that there was what the author said, that there's a shortage of radiation therapy centers in low to middle income countries. I don't think we have to discuss about that. I'm also a visiting professor in Malaysia at the University of Malaya, and I have been serving as a visiting professor at the University of Nanjing, and in both countries, it is an indication for a mastectomy because the patient cannot travel so far to the next center, completely apart from financial problems that are occurring when you have to pay for surgery and for radiation. IORT may offer an alternative to improve radiation treatment efficiency and alleviate hospital patient loads, and I want to add that because that is a citation here from the JCO Global Oncology. I want to add, and may even lead to patients deciding for breast conserving surgery and IORT, because then they would not have these 2 packages, surgery and then paying for radiation, but they can get all that at a one-stop shop. They don't have to come to town for 25 days or for 5 weeks, and that may play a role in maybe even increasing the rates of breast conserving surgery in countries where radiation therapy centers are not so common. In Germany, actually, we have a radiation oncology center at almost every bus stop, just a little exaggerated, and our insurances cover the complete procedures, so there's no out-of-the-pocket expenses at all. But in countries where there are out-of-pocket expenses, and additionally there are not so many radiation oncology centers, IORT definitely is even more important than it is in the country where I work. In this retrospective analysis, the authors concluded that this retrospective study of IORT performed in Africa, the first of its first analysis that we have heard of from Africa now, confirms that it's possible to do it with low complication rates, no detrimental effects with breast conservation, resulting in a positive acceptance and the potential to reduce patient loads. And on the other hand, and I want to add that from my own point of view, on the other hand, sometimes even opening the door to breast conserving surgery for patients at all in some cases. So conclusions and take home, not specifically for Africa, but everything, of course, can be transferred to Africa. In all patients who are candidates for boost irradiation after breast conserving surgery for breast cancer, consideration of intraoperative radiotherapy should be part of the routine pre-op workup. That's actually a no-brainer. If you have the possibility to perform IORT, every patient who is a candidate for receiving a boost should be, at least you should think about doing IORT. We are discussing every patient in a pre-surgical tumor board, and actually, if we also have a tumor board decision when we're doing IORT. In selected patients, IORT can today be offered as the only radiation without compromising the oncological outcome. I've demonstrated you data from the TARGIT-A trial that this is definitely possible for patients over 50 with tumors smaller than 2 centimeters. They actually do not have any problems if they don't have risk factors, but this is something you can decide after surgery then. Preserving the breast by the use of target IORT is oncologically safe, and this is there's 2 words missing in breast tumor recurrence. And in our analysis led to a statistically significant improvement of physical well-being and incidence and severity of lymphedema in patients who had a recurrence in their breast. Patients receiving neoadjuvant chemotherapy should not be denied the benefit of IORT as a boost. Last thing that we did, patients with implants can be safely offered IORT. We don't know exactly the reason for the possible beneficial effect of IORT on non-breast cancer mortality. That needs further investigation. Thanks to Jay, this will be done in the TARGIT-B trial. But at the moment, we can say it is definitely as safe as whole breast irradiation. It is a lot cheaper. It is a lot less time consuming for patients and for radiation oncologists. So actually, we think it's definitely an alternative, and we are using it a lot. And I hope that maybe I've motivated some of you to try it. Thanks for your attention.